Welcome to the Metabolic Classroom, where we learn the intricate world of metabolism and its impact on our health. I am Benjamin Bikman, a biomedical scientist and professor of cell biology. As a reminder, as we get started, I've launched benbikman.com, your new hub for all of my content. At benbikman.com, you can subscribe to become an insider or a pro insider. There are two levels of this sort of backdoor or elite access. As a subscriber, you'll gain access to the show notes of all of the podcasts, some additional podcast content, including the reference list for those of you who want to dive deeper into the science. And you'll also get early access to some lectures that I'm going to be producing, some hangouts or office hours sort of arrangement, and more. All of this with the intention of helping you deepen your understanding of metabolic health. So please, if you're interested in this, go visit the site benbikman.com to learn more. I would love for you to join. So connect with me there. All right, today, the lecture that we're tackling is a topic that affects millions of people worldwide: high blood pressure. Now, this isn't a lecture about the disease per se, but rather, in other words, high blood pressure, but rather the metabolic consequences of some of the most common medications that people use to fight this high blood pressure. And of course, knowing me, it's no surprise to you that the lecture is going to primarily focus on the metabolic consequences of insulin resistance and some unique, where relevant, effects of the medication on fat cells. It's an interesting side effect that some of these medications have of directly affecting the fat cells. Now, as we get started with the lecture, we're going to begin by making sure that you have a definition, a working definition of what hypertension is, what it is, and why it's relevant. And then we will deeply dive into the most common medications, as I mentioned. I'm going to describe them in their kind of respective drug families, these most commonly used antihypertensive medications. We'll break down how they work and then what their metabolic consequences are, including, where relevant, describing some of the mechanisms of how these drugs work in this regard. And then lastly, we're going to briefly explore the relationship between insulin, that humble hormone that I can't ever not talk about, and then also, well, just how insulin affects blood pressure, and then how dietary changes that affect insulin can in turn affect blood pressure. All right, without any further introduction, let's get started. So firstly, what is hypertension and why is it worth describing or talking about? Hypertension is high blood pressure, and this occurs when the force of the beating from the heart is pressing against the blood vessel walls. That's what's creating the pressure. To be very technical, this is called a hydrostatic pressure, akin to the pressure that allows a water balloon to be filled. When you put that water balloon at the bottom of the tap and you turn it on, it's a hydrostatic pressure that is pushing against the walls of the balloon and allowing it to fill. Now, our blood vessels are not quite as dynamic as a balloon is, and so suffice it to say they don't get as big as a balloon can get, but it's that same physical concept of pushing against the walls of the blood vessel. That is blood pressure. A normal blood pressure reading is around 120/80, and the units are millimeters mercury, based on some old metrics of how much pressure does it take to move a little bit of mercury up into a little cylinder. And then hypertension clinically is defined as those numbers getting up to 140/90. And there's various levels. There's kind of grade 1, 2, 3, etc. of hypertension. But the simplest perspective is that once the blood pressure is 140/90, you have clinical hypertension. The reason all of this matters is that as the pressure goes up, it is associated with a significantly greater risk of myriad complications, including heart attack, including stroke, including kidney failure, and even some forms of dementia. So there's a lot of reason to monitor your blood pressure. Because blood pressure matters so much, it's no surprise that there are a lot of various medications that people will be prescribed from their clinician in order to help fight that. Now, what brings us to the lecture is that when it comes to these antihypertensive medications, not all are created equal, especially when it comes to metabolism. And then once again, especially with regards to insulin resistance and fat cell biology. All right. Now, of course, I'm going to mention this again later. I'm not giving you any sort of clinical advice. I'm just your friendly neighborhood scientist who wants to share some biomedical insight with you. But I'm not giving you any sort of diagnosis or prescriptions. All right, let's talk about the most common antihypertensive medications and how they work. The first one, loosely based on order of how commonly they're used. The first one is a class of diuretics, or these are water pills. So diuretics are really the oldest and now still most widely used class of blood pressure medication. Their primary function is to reduce the fluid, the amount of water in the blood. If you reduce the amount of water in the blood, the volume of blood goes down. And if the volume of blood comes down, pressure comes down as well. So less water means less blood volume, which means less blood pressure. Okay, there are the three most common type of diuretics. They all fall into this family called thiazides. And one is hydrochlorothiazide, and I'm going to talk about a study or two in just a moment. I'm going to reference them. And that's the drug name. And then the brand name that you may recognize as a patient, depending on what you or your loved one or friend, the person you're thinking of, has been prescribed, it would be called perhaps microzide or hydrodiuryl. Those are some brand names of hydrochlorothiazide. Another type is chlorthalidone. Those brand names are Thalatone and Hygroton. And then the last of the most common type of medication, the thiazides, is indapamide. And that brand name is Losol. All right, so maybe some of those names sound familiar. That's the only reason I'm even taking the time to mention these awkwardly titled drug names and brand names, is just in case, just to help you recognize one of them, whether it's your own drug cabinet that is holding it or someone else. All right, now, once again, the way these work is by reducing the blood volume. But diuretics in general will target the kidneys to increase the kidneys' excretion of sodium, the mineral or electrolyte sodium. And then where sodium goes, water is generally going to follow it. Thus, blood volume comes down and blood pressure follows it. Thiazide diuretics, such as the most common one I just mentioned, hydrochlorothiazide, work specifically by inhibiting sodium reabsorption in the kidney. In fact, one little part called the distal convoluted tubule. The kidney's got a lot of microscopic anatomy that makes them remarkably complicated organs. But again, suffice it to say, where you have the operating unit of the kidney is something called the glomerulus, where the blood vessels, the capillaries, are encapsulated, and then there's molecules getting filtered, and then sodium included. And then most of the sodium that gets filtered will be reabsorbed back into the blood, except the thiazides, like hydrochlorothiazide, block that from happening. And so the sodium that got filtered at the glomerulus stays filtered, and it's keeping more water with it, having pulled that water in at that same site. And thus we're dumping out more water and blood volume is going down. All right, now that's the main mechanism of action in the context of blood pressure regulation. But remember, the purpose of this lecture is not to talk about hypertension per se, but the metabolic consequences of the most commonly used antihypertensive medications. So let's transition into that aspect of the thiazides. With regards to, and each time I'm going to talk about insulin resistance and then the separate effect, if it occurs, on the fat cells directly. Those are not the same thing. All right, firstly, with regards to insulin resistance, thiazides are known to increase insulin resistance. One mechanism actually involves the depletion of potassium. This is a common side effect of diuretics. So potassium is also getting dumped too readily. And in the blood, we have very little potassium. So a little bit of potassium loss goes a very, very long way, or has a An outsized effect is another way of saying it. Interestingly, potassium is essential for proper insulin secretion and glucose uptake into cells. So when potassium levels start to drop too much, insulin signaling can falter and insulin production can falter, but the compromised insulin signaling is directly contributing to insulin resistance. And this whole effect on blood glucose regulation is compounded by the fact that insulin secretion may also oddly be compromised. Again, the net effect here is some insulin resistance and the potential for blood sugar levels to start to climb on a patient who is taking these drugs. Now, with regards to fat tissue, a classic study was published in the Journal of Clinical Investigation. And just by way of familiarizing you with that journal, that is a very well-respected journal. As a personal aside, one of the great highlights of my postdoctoral fellowship was actually getting a paper published in this journal. It's a very good, prestigious journal. So this paper was published in 1966, and it explored how thiazide diuretics, like the most common hydrochlorothiazide, influence the dynamics at muscle and fat tissue. So the researchers found that when they tested this in a lab setting, which we would commonly say is in vitro, the thiazides did not directly have any effect of insulin with regards to glucose metabolism, muscle, or fat. However, when they looked in an animal, so now it's in vivo, in vitro would be outside of a living thing, in vivo, like using cells growing in a petri dish, if you will. And that, in fact, it is what happened. But in vivo is now you've put it into a whole animal or a human. But in this case, it was rats. So after 2 weeks of chlorothiazide treatment in rats, they found that adipose tissue showed significant reductions in insulin sensitivity. Interestingly, this was not found at muscle tissue. It was selective to fat cells. In 2009, a bit of a follow-up, if you will, so decades later, a paper was published in another very good journal, in the journal Hypertension, which examined the metabolic effects of hydrochlorothiazide in hypertensive patients. The researchers compared this medication, hydrochlorothiazide, to a different one that's in a different family that we'll talk about in a moment in this affecting the angiotensin-aldosterone system. And again, we'll get to that family in just a moment. And they found that hydrochlorothiazide worsened insulin resistance and, now relevant to fat tissue, increased visceral fat accumulation. Now remember, this is in humans. So this finding underscores the potential long-term metabolic consequences of thiazide diuretics, especially in individuals who may be predisposed to insulin resistance or type 2 diabetes. And as you'll see at the end of the lecture, insulin resistance is an extraordinarily relevant variable in causing hypertension. So the person is put into a very frustrating situation where the medication is intended to reduce blood pressure, and it can by forcing the kidney to excrete electrolytes and water that would go with it. But at the same time, it may be increasing what is generally considered to be the main risk factor for hypertension, namely insulin resistance. All right, let's move on to the next most common class of antihypertensive medication. This is a family of drugs called beta blockers. Now, beta blockers, they target these types of receptors found throughout the body called beta adrenergic receptors. Most especially, these are relevant in the heart and in the blood vessels. Now, within that term, adrenergic, you may hear the hint of another word, adrenaline. The adrenergic receptors are specific to adrenaline. And adrenaline is this kind of main famous hormone of the fight or flight response. And I'll kind of mention that. I'll get into that more in just a second. Before that, I want to mention the most common drug or drugs, the molecule drug and then the brand name. So the most common is atenolol, and the brand name is Tenormin. Another one is metoprolol, and that's a brand name Lopressor. And then another one is less common is propranolol, and the brand name of that drug is Inderol. All right. So those are the most common forms of these beta blocker drugs. And beta blockers work by reducing the effects of these the main hormone, adrenaline, and its sort of little brother hormone, noradrenaline. These are the primary hormones of the sympathetic nervous system. Another way of describing the sympathetic nervous system, you've probably not heard of sympathetic nervous system. You've probably heard of the fight or flight response. The fight or flight response is the sympathetic nervous system. It is the amplification of our awareness, and the heart rate starts to go up. Heart contractility starts to strengthen, so the heart is beating harder and faster. And at the same time, systemic blood vessels, so the blood vessels throughout the body, undergo vasoconstriction. They start to narrow. Now, as a brief tangent and a point of physiology, why on earth would you want that to happen? Why would you want your blood vessels to constrict? Because it means the blood will move a lot faster. So it's a great way to be rushing oxygen and glucose and fats, et cetera, through the body to help us get away from whatever it is that activated the sympathetic nervous system in the first place. Now, suffice it to say, by blocking these adrenergic receptors, particularly the beta class, now we are mitigating, we're turning down that response. So this starts to slow and soften the contractility of the heart at the same time that it is enabling the dilation of the blood vessels now. So the net effect on this is to reduce blood pressure. That's how they work. Now, again, the purpose of the lecture is to describe the metabolic consequences of these. With insulin resistance, beta blockers can impair insulin sensitivity by reducing the ability of muscle cells to take in glucose. This happens because they decrease blood flow to muscle tissue. These drugs do. That there's just not as much blood going to muscle with beta blockers, and that means there's limited glucose delivery, and with limited glucose delivery is limited glucose uptake, and so blood glucose levels are higher. Additionally, beta blockers can reduce the release of glucagon, a hormone that balances blood sugar levels, potentially leading to hypoglycemia. And this paradoxically can worsen insulin resistance over time. Now, that's the insulin resistance component. What about fat cells? Some beta blockers, particularly some of the non-selective ones like propranolol that I mentioned, that was the third most common of these. It's used. It can inhibit lipolysis. And lipolysis is the term for the breakdown of fat from fat tissue. This occurs because the beta adrenergic receptors in fat cells get blocked with beta blockers, which reduces the breakdown of fat. So again, a normal effect when the sympathetic nervous system is turned on is that there are a class of beta receptors on the fat cells that gets turned on. And when those beta receptors are turned on, the beta adrenergic receptors at the fat cells are turned on, they in turn activate lipolysis, the breakdown of a triglyceride molecule, pulling off the fats, which would then be going into the blood to be used for energy. But with a beta blocker, you're stopping that. You're blocking that effect. And so you have less lipolysis, which means that the fat cell is holding on to its triglycerides more readily. Now, there is some interesting human evidence. So one study is called the United Kingdom Prospective Diabetes Study, and it highlighted this effect, showing that patients that were treated with atenolol, the most common of all of them, they gained on average 3.5 kilograms over 9 years. This was overwhelmingly fat tissue. This was double the fat gain that was noticed in patients taking a different blood pressure medication, an ACE inhibitor, which we'll talk about. That's once again part of that aldosterone angiotensin system. Also, another study found called the Gemini study, that metoprolol, that's another one I mentioned, was associated with weight gain, but a different use. That's a kind of general beta blocker, but a more selective beta blocker, which is more selective to the beta adrenergic receptors of the heart and blood vessels, didn't have as much of this effect. So depending on the nature of the beta blocker, if it's a very general one, yeah, it will increase your blood pressure or improve your blood pressure by reducing it in this case. But it may also directly compromise your fat cell's ability to break down fat. Now, separate from all of this is that if you are suppressing the sympathetic nervous system, you are also suppressing metabolic rate. And as you are suppressing metabolic rate chronically, That, of course, means there's less energy being expended, which may make it easier for the body to then store that energy. And who better to store it than the fat cell, which is designed in part for that purpose. All right, so that covers the diuretics in the thiazides, that covers the beta blockers. Let's move on to the next most common, the ACE inhibitors. ACE inhibitors, and I'll mention the most common ones in just a moment, focus on a system in the body called the renin angiotensin aldosterone system. For the sake of time, I don't want to get into all of the mechanics of that system. It is a fascinating system that regulates electrolytes in water. You can look this up for more detail, and I've talked about it in more detail in previous Metabolic Classroom lectures. But to say that again, so that you have that reference, it's the renin angiotensin aldosterone system. When this system is turned on, I'll get to that. But it's just another mechanism of the body wanting to hold on to salt, which in turn will want to hold on to water. Okay, but before I get into that, let me just mention the most common forms in case you recognize one of these and realize that you or your loved one or acquaintance are on it. Okay, the first one, lisinopril. Lisinopril. This comes in a few different forms. The most common brand name for this one is Zestril or Prinavil. Another drug in this family is enalapril. This is Vasotec or Epined. Aren't these drug names just ridiculous? Okay, then the last one is Ramipril, and that's Altase. That's the brand name Altase. So lisinopril, enalapril, and Ramipril with their respective brand names, Zestril, Vasotec, and Altase, again, respectively. All right, now those are the most common ones. How do they even work? And these are all ACE inhibitors. ACE stands for angiotensin converting enzyme. So an ACE inhibitor blocks the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 has these direct effects of constricting blood vessels. So just like we talked about with beta adrenergic receptors earlier, if you constrict the blood vessel, blood pressure goes up. It's like, you're forcing this thing to narrow and start to compress the blood more, and the blood's pushing back, meaning pressure's going up. And so by reducing angiotensin 2 levels, the drugs will help blood vessels stay more dilated, which will help blood pressure be down. Further is that if you reduce angiotensin 2, you reduce its activating the release of aldosterone. And aldosterone is a molecule that will directly act at the kidneys to help force the kidneys to retain more sodium. And if the kidneys are retaining more sodium, they're retaining more water. We're going to revisit this topic in a moment when I discuss insulin. But suffice to say, there's sort of two benefits here. These ACE inhibitors are going to reduce angiotensin 2, which has the effect of allowing vasodilation, which reduces blood pressure. But at the same time, it reduces the levels of the last step of the renin-angiotensin aldosterone system, which is the production of aldosterone. And by reducing aldosterone, the kidneys are getting rid of sodium more readily, and then the water would be going with it. So it's back to that kind of diuretic class, mimicking that effect. All right. Now, what about insulin sensitivity in fat cells? Angiotensin 2 impairs insulin signaling by increasing oxidative stress and activating the inflammatory immune pathways, which, as you know, inflammation is a canonical cause of insulin resistance. So by reducing angiotensin 2, ACE inhibitors, this angiotensin converting enzyme, ACE inhibitors can improve insulin sensitivity. And this is at least partly because of tissues like skeletal muscle, where the ACE inhibitors have been shown to improve glucose uptake. And the more easily you're pulling glucose into muscles, the more easily blood glucose will be under control, and the more easily insulin will then also be under control. All right, so that's a net benefit. At the fat cell, angiotensin 2 is also involved, and here it is directly promoting adipocyte growth and differentiation. So it is both promoting the growth of fat cells and the birth of new fat cells. So that's what angiotensin 2 is doing. ACE inhibitors are blocking this effect by reducing the amount of angiotensin 2. Thus, ACE inhibitors actually have a more favorable metabolic view than any of the other blood pressure medications that we've talked about. Now, there's some interesting further dynamics where adipose tissue can express other components of the renin-angiotensin-aldosterone system. And I'm not going to get into it. In fact, I ought to make that its a whole other metabolic classroom. In fact, that even has echoes of COVID, one of the most controversial topics ever, insofar as COVID, the virus, could invade cells through aspects of this angiotensin, the renin-angiotensin-aldosterone system. And because fat cells express so much of these receptors, the fat cell was a welcoming host for viral particles. And so fat cells would get infected very easily. This is very likely why people who struggled with obesity were more likely to have consequences with COVID infections. Anyway, I know, super controversial topic, but a very interesting dynamic. And again, there's more to say about fat cells and this overall pathway, but that's going beyond the scope of this lecture, which is intended just to talk about the blood pressure medications. So to wrap up that part, ACE inhibitors, while being effective for maintaining blood pressure, are also considered metabolically protective and are actually often recommended for individuals with type 2 diabetes and insulin resistance. Okay, the last one, just to be thorough, is less common. This is a family called calcium channel blockers, and they essentially are just easing the flow of blood. So calcium channel blockers, and I'll give you the name in a moment, act on the smooth muscles and of the blood vessels and on the heart. So in cardio, now by way of, here's some physiology background, some cardiac physiology background. Calcium is essential for initiating and sustaining contraction of the heart muscles, these cardiomyocytes. The cardiomyocyte is the name for the specific fat cell. When you lump a bunch of cardiomyocytes together, now you have a myocardium. During each heartbeat, when the heart is contracting in this rhythmic, it beats, here's the structure of the heart. It beats at the top first, pushing blood down. Then it beats at the bottom, pushing blood up and out of the big vessels like the aorta or the pulmonary arteries, going to the lung from the right side of the heart or going out to the body if it's coming from the left side of the heart. So during that heartbeat, that rhythmic ongoing contraction and relaxation, calcium molecules will enter, or ions will enter into these cardiomyocytes, these heart cells, through these things called, through these calcium channels. It's I don't want to make it too complicated, but with the influx of calcium, you have the triggering of the release of more calcium from these other components, these other parts of the cell. So with these calcium channels being opened or active, calcium comes in, which stimulates the release of more calcium. And then all of this calcium is what physically enables the contraction of the muscle cells. All right. But again, it all started with the calcium channel. Now that's the heart. That's heart muscle, which is a separate type of muscle, separate even from skeletal muscle, which is moving my body around and your body. And separate from heart muscle is the smooth muscle. And we have smooth muscle in a variety of places throughout our body, including our intestines with peristalsis. How is food and its waste moving through the intestines? Well, that's smooth muscle. This is muscle that we can't control. But once again, it is heavily regulated by calcium, where you have calcium channels that open up and the calcium comes in, which induces the contraction. This happens around blood vessels. So when blood vessels start to constrict, indeed through the mechanisms I've mentioned previously now, it's because of the influx of calcium. So now we're getting to this this sort of last step that both the beta adrenergic receptors precede this, angiotensin 2 precedes this. If both of those are inducing a vasoconstriction, it's because of calcium. So we've kind of gone to the last step. Now, so now you know how calcium works. Let's talk about the drugs in both the heart and the muscle around our blood vessels. All right, the drugs. The first one is amlodipine, the brand name Norvasc and Catersia. Another one is diltiazem. The brand name is Cardizem. And then the last type of this is verapamil, and that takes the brand name of Calin or Calan, C-A-L-A-N, and Verilan. Those are the most common brand names. So maybe you'll recognize some of those drugs. Now, how do they work? That is obvious, I suspect, now. Now that you appreciate how this calcium influx starts with a calcium channel, if you can close those calcium channels a little bit and let in less calcium, then there will overall be less calcium within the cell. And less calcium means two things. Well, one in each of these spots in the heart and in the smooth muscle around the blood vessels. Firstly, the heart is going to beat a little slower and softer. That's going to lower blood pressure. And then second, the blood vessels and the smooth muscle around the blood vessels are going to be less likely to be constricted. They're going to be more dilated, which means blood pressure will be down. Now, what are the metabolic effects? Calcium channel blockers are generally neutral. There's not much to say. They don't really have, there's little evidence or none to show an effect on insulin sensitivity or insulin signaling. There's no direct effect there. And similarly with fat cells, there's no significant effects on fat cells that have been observed in any research. So when it comes to metabolic outcomes, these drugs are generally neutral. Now, that is not to say they are benign and without consequences. There's a consequence to not allowing the heart to beat as hard as it may want to beat, depending on what your demands are on the heart. So please don't think that this is me giving them a green light. It's just strictly with regards to metabolic outcomes, they are neutral. All right. Now, I felt and feel inclined as I wrap up to just remind you of something I've discussed previously, which is the effects of insulin on blood pressure. Insulin has numerous effects to regulate blood pressure. In fact, there are several distinct effects. I'm going to mention the two most prominent, which is insulin's effect directly on vasodilation and then insulin's effect on aldosterone. I'm going to be brief for the sake of time. Firstly, insulin normally has the effect of inducing vasodilation by activating an enzyme called endothelial, and the endothelium is a lining, the innermost lining of the blood vessel. Endothelial nitric oxide synthase. Basically, when insulin comes to the blood vessel, knocks on the blood vessel door insulin receptors of the endothelial cells, saying, hey, it's time to make nitric oxide, and it does so by activating eNOS, endothelial nitric oxide synthase. Where there's more nitric oxide produced, there is vasodilation. However, if the blood vessel or the endothelium has become insulin resistant, and this is work of a colleague and friend David Simons at the University of Utah, when the endothelial cells become insulin resistant, now there's less nitric oxide produced with insulin, and so the blood vessel stays constricted. At the same time, insulin is a powerful stimulant for aldosterone. And I've mentioned aldosterone now, but when insulin is up, it increases aldosterone activity. And where aldosterone goes up, now it's telling the kidneys to hold on to salt more, to reabsorb it all. And when it reabsorbs that, it's holding on to more water. And if the body is holding on to more water, blood volume is high. And if blood volume is high, blood pressure is high. Now, all of this brings me just to one final point, which is commenting on the DASH diet. I would be derelict in my duty as your temporary professor if I didn't mention the famous DASH diet. It stands for Dietary Approaches to Stop Hypertension, DASH, DASH diet. It's an eating plan, a diet designed to reduce blood pressure. That is the main purpose. So this antihypertensive method of eating or diet. It emphasizes whole foods like vegetables and fruits, minimally processed grains, low-fat proteins like low-fat meats, and then low-fat or fat-free dairy. While at the same time, or as a part of this, explicitly encouraging the avoidance of saturated fat, the avoidance of sugar or refined starches and sugars, and salt. Okay, so it's eating kind of minimally processed foods, largely plant-based, low-fat meats and low-fat dairy. Avoid saturated fats, avoid sugars, and avoid salt. Now, it may not surprise you to learn that this works. There is abundant evidence to show that if you eat like this, blood pressure is going to go down. And people will use this to claim salt restriction works. So all of the evidence that is saying salt restriction works is based on the application of the DASH diet. But can you see the problem? This diet has a lot of moving parts, thus there are some confounding variables. An often overlooked but critical component of the DASH diet and how it's effective is because of what it does to insulin. By also, yeah, sure, they say reduce your sodium, but by reducing the intake of refined starches and sugars, which is a part of the DASH diet, you are helping improve, you're helping lower insulin, and which helps maintain, which helps with insulin sensitivity. And I just described two of the 4 or 5 distinct ways whereby insulin resistance contributes to hypertension. So that's one very important thing to consider about the DASH diet, that people want to invoke the DASH diet as a defense of salt, but you could just as readily invoke the DASH diet as a defense of restricting salt, I should have said. You could invoke the DASH diet as a defense of restricting sugar, because that's just as much a component of the DASH diet. Also, people will cite the DASH diet as evidence to reduce much maligned saturated fat. Now, from an insulin-centric perspective, which admittedly is how I view most things, fat itself in the diet does not affect insulin levels. So blood pressure improvements should be seen regardless of fat consumption if sugar and refined starches are reduced. This very concept was studied in an article that has not gotten nearly enough attention. Help me make it more popular. It was published in the American Journal of Clinical Nutrition, and it explored a high fat, indeed a high saturated fat version of the DASH diet. So they encouraged the consumption. They said, follow all of the same guidelines of the DASH diet, whole fruits and vegetables, reducing sugar, reducing salt, etc. But anything that comes with dairy or meat, eat high fat versions. So, and they compared two groups, one following the low saturated fat version of the DASH diet and the other eating a high full fat version of the DASH diet. Given everything you know about insulin and its role, not surprisingly, the high fat version of the DASH diet lowered blood pressure just as effectively as the traditional low fat DASH diet. The key, of course, was the reduction in refined starches and sugars, which helps keep insulin low. Even further in this study, the high saturated fat version of the DASH diet improved triglyceride levels more. And triglycerides are very, very important, but also they didn't increase LDL cholesterol. It was inert with LDL. It was changed just as much as the low fat version of the DASH diet. So a very, very compelling view on helping de-vilify saturated fat. Now, one final comment, of course, with regards to this lecture as I wrap up. If you're currently on blood pressure medications and you're thinking of a low carbohydrate diet based on some of the comments I've shared or other things you've learned, please, you have to maintain close contact with your clinician. Now, this is more relevant than me just wanting to protect myself. Blood pressure is so immediately and heavily affected by insulin that if you adopt a low carbohydrate diet, it is very likely that your blood pressure will drop so quickly that you will need to consult your clinician to help you adjust your medication dosage if you're on a blood pressure medication, because your blood pressure may drop so low so quickly. And I mean like within days. I've known enough people, which is why I'm so inclined to talk about this, that have to change their doses literally within a day or two upon adopting a low-carb diet. So you really need to be careful and consult your clinician, because something's going to happen, and it's going to happen quick. All right, now, final notes here, final thoughts. Understanding the metabolic effects of blood pressure medications, I believe, is crucial for you personalizing care for yourself or your loved ones. You don't want to be taking a medication to improve your blood pressure if one of the side effects of said medication is that it worsens your insulin resistance, what is the main risk factor for high blood pressure. I hope all of this has been helpful and insightful. Thank you for joining me today on the Metabolic Classroom. I do hope you enjoyed the discussion and you found the lecture enlightening and, perhaps most importantly, practical. Until next time, more knowledge, better health.